Hi everyone, I'm Anna Shah, social prescriber at Seven Kings PCN. Just been in the role just over 6 months and thoroughly enjoy it. I've been able to use all my experience from other roles. So yeah, really good. I come from a health and social background, can tell you more about that later on. You have my email address. So, what is social prescribing? Social prescribing is where health professionals refer clients to the social prescribing service. Social prescribers provide interim advice and information and then refer clients to predominantly into the third sector, voluntary community enterprise sector, and sometimes to the statutory sector as well. So it could be housing, safeguarding, etc. And sometimes even when cases go beyond their limitations to health professionals, i.e. GPs and other health professionals, if needed. In some areas, we also have clients self-referring into the social prescribing service itself and other services directly referring into the social prescribing, such as the fire service, housing, social services, etc. Okay. So why social prescribing? Michael Marmot said action taken by the Department of Health and NHS alone won't reduce health inequalities. Who has high caseloads here? Who thinks the NHS is stretched? The health system, a person's lifestyle and their genetics aren't the only thing that determine health. And we all know that having a good education, a good start to life, a good job and income, strong social networks, good social networks, and social community contacts, access to health and healthcare, the ability to go to a gym and knowing what exercises to do, eating good food and having availability of good food is all helpful to good health, including also the accommodation we live in. Has it got mold? Are we able to afford the accommodation? How about the environment? How about the air pollution? Or is it good air that we're surrounded by? How about the overall social environment? Is it a high crime area? Are you living in an estate or are you living around peaceful, nice neighborhoods? And all that is important to sound health. And those who don't generally suffer ill health. So it makes sense to address these barriers stemming from social determinants in order to curb health inequalities. And COVID has exacerbated inequalities and had an impact on all these social determinants. So how does social prescribing work? Social prescribing adopts the theory of salutogenesis. Saluto meaning health and genesis meaning origin, origins of health. And it depicts health as a positive sense of well-being rather than illness and disease, pathogenesis. Anton Novisky, who coined this term, said, we all go through stress. It's about how we respond to it, having a strong sense of coherence, and in that having 3 elements: ability to comprehend, ability to manage, and ability to have meaning and purpose in life. And if we don't, there's no point. And in order to have a strong sense of coherence and these elements intact, we need to have generalized resistant resources. And these are constitutional, genetic, and psychosocial resources. So it could be anything from money, social connections, good housing, everything we said in the other slide about social determinants. And you can see here, after Anton Novisky's passing, illustrated by other authors, that in the river of health, that just having cure, just being able to access GP surgeries in time and access to hospitalized care does not necessarily leave you in good health. We need everything else: protection, prevention, being educated about health and health promotion in order to stay afloat in this river of health. Otherwise we drown and the end point is death. So taking this one step forward. So salutogenesis is an asset-based approach and looking at health through assets and strengths. Ziegler and friends, his team suggested that the asset-based approach is favorable to curbing health inequalities. And in 2010, Foot and Hopkins said that even the most marginalized communities and individuals have asset strengths, i.e. the glass is half full rather than half empty. And Anton Novisky and Foot and Hopkins contested the conventionally known medical model today. They said that it sees people as deficient, deficits, and with problems. And it looks at health in a negative manner. So people are naturally dependent on services and have a learned sense of helplessness. On the other hand, having community-based development, it looks at people as having strengths, assets. So people are active participants in their care rather than passive recipients. So how does community development work then? Well, we need communities at the heart of the system. No matter how good the NHS is, we've tried and tested different approaches, and here we are today still talking about the same subject, health inequalities. And why have we got them 20 years on? Regardless of the amounts of resources and money being poured in, communities are essential. They have knowledge, skills, and ideas. They know the local population and the issues we are facing today. They have social networks, and community development helps build more networks and social capital. Action on social determinants must have a collective effort from all parties. That's individuals, communities, the government, the third sector, and even the people with lived experiences, those involved in crime, those who are homeless, and those with illnesses, to shape and inform our services. So there's a shift in power. Individuals having power, communities having power and a voice, and able to participate, form new groups, and have sustainability and self-manage their own care. There's a shift in power in the services that exist and the statutory service. Instead of a top-down approach, mindset changes, and they start seeing the seeds being planted and engender a bottom-up approach. Other services are being seen for their potential, i.e. the arts, culture, and nature service. There's so much evidence suggesting that this Cinderella sector has potential, vibrancy, and has contributed to health and is essential. Community development has 5 elements: community empowerment, collectivity, participation, human rights and equality, and social justice and sustainability. And that's what we have to foster in our practice. Such an approach enables a shift in power, as we said, in order to curb health inequalities. This is important because health inequalities exist because of an imbalance in power. So, So who is social prescribing for then? It's for those who are vulnerable, those with long-term conditions like type 2 diabetes, and it's for those who use primary and secondary care the most frequently. And it's for those who have low level and long-term mental health. How about the benefits? It benefits individuals, communities, and services. There's so many benefits. I'm not going to go through all, but just a summary. Increased activation from patients, that's individuals and communities, participation and self-management in their own care. There's high satisfaction from them and those who've experienced through social prescribing interventions for their needs. There's also an increase in emotional health and well-being and mental and physical health, and also cuts in costs and a reduction in the visits to GPs and to hospitals. And here we have some stats suggesting a reduction in GP consultations and reductions in A&E. So the type of referrals then, what type of referrals? So it's any health and social issue that can be addressed through a non-medical intervention. So it can be anything from housing to type 2 diabetes, to cholesterol, to hypertension, to school bullying, to abuse, anything. And it all depends on the geographic location your service is based in, and that would determine what type of needs that are present. So lastly, how does this all work in practice then? Well, I've done a Venn diagram of what I had to do. So through starting the service, through trying to design the service, and any resource development and delivering the service. Central to all, I think, is organisation, the importance of taking initiative and teamwork, and none of this is set in stone. It will be revised as your practice goes on. You know, you go through that. And also what is important, that although social prescribing has been in the arena for decades, really, it didn't have much backing. Started off as a grassroots community development, but didn't really have the name social prescribing. In Tower Hamlet, social prescribing services have been established for over 17 years, and they've supported new social prescribing services to go forward. But it's only because of the NHS long-term plan and universalised personalised care and the backing of Matt Hancock that we are here today, and my role is here, and so is everyone else's. But 9 out of 10 times, if you are a new PCN social prescriber or to be one, there won't be a social prescribing service yet in your PCN, and you're going to have to draw it, you're going to have to develop it and deliver it. So it is the designing of the service pathways, the referral process. You and I know that GPs and staff are incredibly busy and they don't want a long referral form. So you have to think about all that quite creatively and work in a team. You have to try and establish and develop relationships in-house with the practice managers and the admin staff and the GPs themselves and anyone else, and the external partnerships, the third sector who you're referring clients into, and also the statutory sector who you may refer to, and also challenge while you're supporting your clients. And in your delivery, adopting the ethos of community development and salutogenesis, looking at health positively, empowering people using a client-led and personalized approach, ensuring that you work holistically and address the factors that are not only coming in with the referral. So you might have a referral for anxiety, but addressing the underlying factors, investigating what is causing that person's anxiety. Is it being unemployed, a housing condition, being abused, or whatever it is? And it's about supporting the family unit. Is the person coming to you and talking about their mum needs support, or their mum is depressed, their father is like this, or their brother is like this? It's about supporting the person as a whole. It's not really about the 10-minute, 7-minute consultations GPs have. It's about more than 10-minute, 15-minute, 20-minute to 40 minutes to however much time that case needs, and revisiting that. And it's about advice and advocacy and challenging things. So I hope that was helpful for anyone who is a newbie to social prescribing, who's just started in a PCN as a social prescriber, or if any of the staff are having new recruit social prescribers and would like any support from myself to start up a service, I'm happy to be contacted and support them, etc. So Thank you very much for listening. Thank you.
Thank you, Anna.
Thank you.
Okay. Next, we're going to hear from Raquel a bit more about social prescribing. And I wonder if you could just click at the top, stop share screen.
Oh, sorry.
It's okay. Thank you. Okay, so I'll hand over to you, Raquel.
Brilliant. Hello, thank you. I'm just going to try to share my screen now. And I hope we're there.
Yeah, I can see that. Thank you.
Perfect. Thank you very much. Thank you to Anna first for putting a really good show in terms of the timeline of social prescribing, what it means. I think she's giving us a very good foundation. A lot of information there to be digested, of course, for people that is new to social prescribing. But from my side, I'm going to present a little bit of a personal journey through what social prescribing means to me and the lessons that I learned so far. And I hope that you enjoy and you see this useful for yourselves. So going back a little bit again to what social prescribing is, and Anna is made a good point. You know, although this is a recent NHS approach to addressing health inequalities, it has been there for many, many years. But one of the definitions of social prescribing in terms that I found most amusing was that it means a social movement entering a big institution such as the NHS. And this is going to pose a lot of challenges because this needs a change of culture, of visions, of values, and you know, it's not that easy. So, and it's going to take time as well. So yeah, it is a shift towards personalizing care, and perhaps as well about population health management. That's got to do a lot to do with the culture at current GP practices. So then again, just to put a lot of emphasis on, you know, there needs to be a sort of change in culture. As Anna said, it allows health professionals to refer patients with no clinical needs to a link worker that will look at the whole person and will most of all give time. And I think that's what social prescribing is for me, someone that actually can give the time to the person. Anna pointed out as well, you might get a referral with a couple of main reasons that that person will be beneficial for a social prescribing appointment. But then you'll probably find that while engaging into these lengthy conversations, when the person can open, when you can go under the skin of the reality of that person, the priorities or the what matters to the person is really something different. And we have to be very flexible in terms of focusing and helping the person to reach whatever it is their goal. And it might not be that one that was first on the referral form. So yeah, we are, I mean, our roles are really complex. We navigate everything from, you know, motivational interviewing and health coaching at times, and, you know, being very knowledgeable of our local areas, of course, to be able to signpost to services that they might find useful, but also creating resources that are evidence-based, that we are sure that are safe for them to use and to access. So yeah, I think that, you know, we are all social prescribers. We all give advice to our friends, to our families. We tell them, have you tried this? Have you tried that? So this is really what we're trying to do. You know, we're trying to find out what is worked for the person, what they tried in the past, you know, what is new out there, and try to work through whatever it is that they want to change. Something that is really important for someone that comes new is the adaptation to what the NHS organization looks like. For me, it was very new. I come from a background in residential care for mental health, which is very useful as a background to my work, the work that I do right now. But of course, you know, I was micromanaging something from all sides, and here you find structures, hierarchies, and you know, very diverse teams, which is amazing. You know, a lot of resources to use, but it takes time to adjust. So PCNs are relatively new, like us, like link workers. So I suppose that they are trying to adjust to it as well. And as we came in, other additional roles are coming in, like the health and well-being coaches. I think we have in Jamie to talk to us about this role too, and care coordinators as well. Perhaps PCNs are thinking to recruit mental health practitioners, especially now, that are very, very necessary. And we see a lot of referrals with complex mental health needs. Pharmacists are being recruited as well. And I think there is a lot of hope for the future in seeing such a diverse team that can help individuals from all levels. And one of the most important things in working in such complex organizations is communication, of course. You know, if we really want to deliver that personalized care, we really need to be communicating well with each other. You know, we will be able to target interventions, you know, to work collaboratively and really to be more proactive, which is all going to end in providing outstanding care to our patients, and that's all that's our aim. And as I said again, a lot of emphasis on this. These are our new ways of working for everyone. So patience, trust, and collaboration is very, very necessary. A lot of patience there while everything develops. As I started, the induction was quite amazing. I am very lucky to have a network of people supporting me from the start. My induction was really organized. I had a lot of meetings, a lot of networking, a lot of resources to go through. So, you know, we find very useful the NHS e-learning hub, which is got a social prescribing module for all new link workers there, that it keeps adding new information as we develop, you know. The future NHS collaboration platform is got a dedicated space for social prescribing as well. They provide fortnightly webinars. There is a lot of events, a lot of resources, a forum where all social prescribers across the country can type in their questions or their ideas, and we are able to hear and speak and help each other. I find that really useful as well. Of course, there is a National Association of Link Workers. They provide 4 training certificates as well that you can carry online. They share best practice and the code of practice. I will recommend everyone to read it because it's both for link workers and GPs. And of course, this is very good news. There has been a current inquiry about our professional registration. And for anyone interested, in the last webinar of the series, which is with 3 of them, is on the 21st of this month. We do have a London Regional Learning Coordinator that I found uber supportive in this journey. She delivers as well peer support groups with other link workers across London and different STPs. So you can join many different peer supports. And again, it's an opportunity for link workers to see how other PCNs work, how other link workers work. Very, very useful. We also have to think about tailoring our own training needs. Each PCN is unique, and you know, you might find that most of your referrals are coming through and there's a high volume of those with long-term conditions, specifically diabetes or I don't know, cancer. So you have to be very close to your training hub and sort of work with them and see, you know, what is it that you need. the list will be never ending. And that's the thing, you know, we will never have enough training on every single condition and every single type of motivational interviewing and coaching. And it is really an ongoing learning adventure, which is amazing anyway, because it allows us to learn something new pretty much on a daily basis. And something that takes a lot of work on the first 3 months, I'll say. I think the induction will take along 3 months between the service designing, like Hannah said, the implementation, and you really having a sense of the area that you work at and the services that are already available in there, and also the services that they aren't available, you know, and who is the person that you have to reach to say, okay, I found a gap on the service delivery, and who can I talk to? So there is a lot of networking involved in there. You'll see that a lot of your hours will go like by emailing people, calling people. But it is really exciting and really enjoyable. And this is when I come to that entrepreneurial feeling that I had when, you know, it's quite overwhelming, but at the same time so exciting, because you feel like you are your own CEO of a business that you're trying to start. And you know, it's both exciting and scary at times, because you're thinking, oh my God, am I doing this right? And could I be doing things differently? And like Anna said, you know, nothing is set in stone. We sort of continuously refining our pathways, forms, the delivery, how we contact clients, how we speak to them. Everything is in constant change. But that only means that we are suiting the needs of our patients. So I think it is amazing. Red Bridge, as Anna said, I mean, Anna was hired a little bit earlier than I did, but you know, the maturity of social prescribing varies greatly across all the PCNs. In Red Beach, in this case, we've been recently recruited at the end of last year, so we are still in our infancy, and new link workers are being introduced. They are supported most commonly by the clinical lead and the network manager. And yeah, so I think I just wanted to say that, you know, a really, really amazing feeling of you know, delivering something for yourself and creating something from scratch, you know, but with that needs a lot of passion and a lot of dedication and a lot of support too. As I said, you know, you're not only going to find the support on your close team, but you're going to find the support on those contacts that you make in the community. I really can tell great stories of services in the community that have offered their services, their time, even their office spaces, to say, if there is something that you want to develop, you know, we are here. So, you know, I think something about this role is that relationship building. It is very important. It's probably, I'll say, 50% of our role. Skills, loads. So Anna said many, and here you got many more. Service designing and marketing. We really find ourselves as having to market this service to everyone, to GPs, to practice managers, to nurses, anyone that could really make a referral to us, you know, and might not be very familiar with social prescribing, because as we said, it is really new. The mapping services, the building relationship, assessing referrals, you know, really getting to grips with what is a good referral and what is not a good referral, and actually feedback all that information back so that we continuously improve the process. Care planning, data collection and reporting, management of GP systems, networking and building relationships within the team, not only outside, managing referrals, providing the ongoing emotional and practical support that our patient needs. I don't think Anna has mentioned, but something that we do, and again, that it will vary between PCNs, is that we provide lengthy sessions, can go up to an hour, depending on the unique needs of each individual, but and they can be from 6 to 12 sessions. So, I mean, that is a constant, ongoing emotional and practical support that we are able to deliver there. And of course, we need to evaluate our services. You know, we really need to find out from patients and the people that access the service themselves on whether it is helping them or it is not, and what can we do to implement changes and improve the service. As I said earlier, this is a never-ending learning journey. So, you know, bear in there with us. Something very important that I had to learn is that we have to be very, very flexible, but we also have to learn to set boundaries to our own well-being. This is all just for the benefit of our own well-being. Being hired on a pandemic is not an easy ride. You find yourself on your own, working from home, you know, and although the support is there remotely and you have a lot of meetings and a lot of phone calls, you know, it is quite tough and it can be overwhelming at times. So, you know, I recommend each new link worker to think about their time and their capacity. You know, what can they realistically do? Because when you start something from scratch, everything is almost like a dream and you think that everything is going to work perfectly. But when the referrals start coming, and you have to get to the practicality of it, a lot of things start to bubble up to the top, and you maybe didn't think too much about, or whether, you know, you're trying to do more than you can, and it can get a bit overwhelming. So think about the time and the capacity in realistic terms. Think about the patient expectations. You know, some people might think that you're going to be able to help them with everything, absolutely everything, and you know, we have to think that the social prescribing worker is a facilitator role, it's not a doer. So we really need to work with the willing. We're not here to do the work for anyone. We also have to manage the referrals, and I don't think we have to. I think that is interesting to find from our GPs or other referrals what do they expect from us. What do you expect from someone that is being sent to social prescribing? And also learn. There's a lot to learn there. So very interesting. Again, they keep learning. You know, I can't stress enough how important it is to have that peer support. You know, there's days that you feel up high, days that you feel really down, and just stepping into one of those peer support sessions or calling your network manager and saying, hello, I don't think I'm doing well today. And, you know, it takes courage to say that, but I think that honesty and being humble will win you a lot in this role. But there are opportunities to do that, so please do use them. And find time to offload. Oh God, yes, as I was saying, you know, if you have that one person that is a good ally or a good friend that you make on the way, you know, give them a call, offload, be there for them as well. Very, very helpful. And just as I was saying, be kind and compassionate to yourself, because we can get lost in the amount of human stories, very, very complex, very, very tough, that we approach on a daily basis, you know, hour after hour, and it can get very intense. So do not forget about being kind to yourself and finding that time to offload. Going back to community, and you know, something that we really need to focus on is in the understanding that without our communities and their services and the voluntary services in the third sector, social prescribing wouldn't exist. And you know, I found that perhaps there's been the coming of link workers at the NHS level has been a bit of a challenge. You know, we find that services perhaps didn't feel supported, or that we might be stepping into each other's toes, and it's got nothing to do with that. It's got to be collaboration. It's got to be us lending a helping hand, and again, working together to really get a lot from the community, because it's really where our well-being resides. They are at the heart of our community. You know, they are our assets. If we don't have community services, we can't do anything. You know, we can be there for the patients, but we cannot make any referrals to any groups. So they need a lot of support. A lot of services were already running with their own social prescribing models and systems and working ways, and we really have to come in and adjust again to them, or perhaps finding new ways of working. That is a lot of work that we need to do on the background. We really need to think about the funding. If there is no funding, again, for these services, we couldn't really move forward. So perhaps the NHS has got to think about where the funding goes, you know, and really supporting communities in that way. We have to realize that by giving people all this time, we are making them powerful. Like Hannah was saying, this is a system change, you know, we're giving them a voice, letting them tell us what they need. And we really need to understand that in terms of that person is part of a community that probably has the same views and values and goals as a lot of people in the community, and probably supporting those people to also, you know, up their skills and get more involved. So we're really just building better communities for everyone. But also, I wanted to talk about the risk of over-standardizing everything in terms of systems. The beauty of social prescribing is that it is unique and it's non-medical. So let's not over-standardize systems so that we can carry on offering what we really are supposed to offer, you know, which is a very, very flexible sort of support and yeah, avoiding getting too strict with norms and rules and regulations. How does the future look like? A lot of more link workers coming in, which is amazing. You know, I can see myself and probably Anna and everybody else, the number of referrals keep piling up, and you know, so there's really demand for more link workers. That means that all of these personalized care roles will be working together, which will be great, but we also will be working with the community. So to make actually well-being accessible for all, which is, I think, the big dream of social prescribing. We will need more funding, so that is going to be a hot and press thing, a lot of more funding for all the services and projects in the community. Hopefully, I would love to see well-being hubs in our local at either the borough level or the PCN level. I'm not too sure about that, but Bromley by Bow Centre is an amazing example that I recommend everyone to visit their website and see what they managed to do, having medical and non-medical services all brought together into a big building that is like fuming with vitality and services and volunteers. It is quite amazing. So I will really think that you know, we'll get there one day. People taking active roles, finally, you know, I think what we're helping is we're helping people understand that they got the skills, the knowledge and the confidence, you know, and if they don't, we are helping them to get those, you know, so that is going to have a repercussion into the community. And then I think it's a snowball effect. You know, creating happier and healthier communities is really our goal. And of course, yes, we hope to provide less pressure to GPs so that they can focus on what is really important to them. But in the meantime, and while doing that, we don't want to focus on quantity. We really need to make sure that we focus on the quality, because then our works means nothing. So I think I hope I didn't rush. Again, just to remind you that that was my personal account, what I think I encountered along the way, how exciting it is to really come into this role and to see what the future look like, and you know, to see all these other roles that are coming into the team. I can't wait. I can't wait to see how this goes on. Thank you, everyone.
Thank you, Raquel. Okay, and next we're going to hear from Jamie, who's a health and wellbeing coach.
Hello, good afternoon, everyone. My internet's a bit unstable, so just bear with me. I apologise if it doesn't work too well. Okay, so I'm just going to share my screen, so you should see that now.
Yep.
So yeah, hello. So my name is Jamie. I am a health and wellbeing coach in Fairlock. Sorry, wrong slide. Fairlock PCN, and I've been in the role since October now, so about 5-6 months. When I first started, the role is a very new role. So it started, I think they only started to recruit people last year, and the emphasis was to start a service from scratch, which was quite overwhelming, but I had lots of ideas, and starting it through COVID was quite difficult, obviously being virtual. But yeah, I've managed to come along leaps and strides. So yeah, I'm just going to keep it quite brief and short, just to explain what health and wellbeing is in my opinion, really. So to start with, health and wellbeing, I'm just going to use this psychosocial model, which is basically 4 aspects of health and wellbeing, which is physical, which is your physical health, so your diet, your exercise, you smoke, drink alcohol, sleep, all the obvious factors that affect physical health. You have the mental side, which is your mental health, obviously, your emotional well-being, you're feeling content and happy in lots of areas of your life, kind of financially, relationship, and so on. Your self-esteem, your self-confidence, your mood, etc. You've got your social side, which is your social interactions, so your relationships with friends, family, colleagues, partners, and having healthy, strong relationships obviously impacts your well-being. And good social interaction, which is obviously at the moment is very difficult because we don't have much social interaction physically. We have maybe on the phone, or some of my patients don't necessarily talk to anyone through the whole day. They live on their own, so it's quite a tough time to have no social interaction. Lastly, your environment. So your environment is obviously your home, your work environment, your social environment, where you travel to, like your local shop, your local area. All these impact your overall well-being. So moving on, just going to minimize this. So what is the role of a health and well-being coach, and who is it for? So the role of a health and wellbeing coach is to work with patients with one or more long-term health condition who are struggling to manage in some way. So for example, patients who've got pre-diabetes or diabetes, and they're struggling to lose weight or to bring their weight down, and also bring their HbA1c levels down, and to really control that and be confident in dealing with that themselves. Struggling to manage with depression, stress, or anxiety. So I help patients deal with low-level mental health issues. They have COPD, could be struggling to be more active and exercise a bit more and improve their lung function, and also their overall mobility. I have a patient at the moment who's got MS, so that's quite challenging, trying to get her to be more active. Using health coaching skills, we support people to become effective self-managers. So basically, we're trying to empower patients and equip them with knowledge and solutions. We work alongside them to create these solutions that they can go forward in life, because a lot of the habits and the things they want to change are developed over a long period of time. So it's not a quick fix. It's not medication. It's not just do this short diet, or it's a long-term solution. So we support patients to develop the knowledge, skills, and confidence to become active participants in their own care and not be reliant on healthcare services. So support patients to engage proactively with other services that can offer help when they need it, such as condition-specific education and peer support. Okay. So what do we do? What do coaches do? Health coaches work alongside people to coach them through multiple sessions, supporting them to self-identify their needs and set and meet achievable goals. So coaches deliver a supported self-management health coaching program. We allow patients to be heard to facilitate them finding realistic solutions to problems with health and well-being. which usually consists of 6 weeks of coaching, currently which is online or by the phone due to COVID. And we then, when we finish the 6 weeks of one-to-one sessions, we leave it, I leave an open door policy where patients can contact me if they down the line have a hiccup or they have any concerns or questions. They can reach out to me, and I'm happy to, just be contactable basically, so they're not feel like it's just 6 weeks and then they're left alone. So patients usually like that. The program is non-condition specific, so it's designed to support patients to gain a greater sense of control over their long-term health condition or living life with long-term health conditions, which a lot of patients do need to do. So how patients are referred to my service, patients can be referred using the referral form that is shared to the practice managers, the GPs, practice staff, so any admin, nurses, etc. at the practice. So anyone can refer, it doesn't have to be a GP. Social prescribers can also refer patients. A lot of our work crosses over, so we can refer patients between each other, that is more suitable to one or the other. Patients can also self-refer via email. So I've made it quite easily accessible that patients, you could just share information to the patient and they could contact directly, and then we arrange the assessment and deem whether they're appropriate or not. Practices can target certain groups, such as they could target pre-diabetics or diabetics who seem to be struggling or they're unable to reduce their HbA1c levels or their weight or their blood pressure, so on. So they send the info of the service and how they refer themselves to the patient directly, which is what I'm doing currently. I'm currently making a group virtual clinic for a list of pre-diabetic patients for the Willows, which is the surgery in Fairlock. And it's for pre-diabetic patients who are at high risk of developing diabetes. And we're working on a 6-week service with consultants, GPs, diabetic specialists on how to educate patients and also inform them and equip them with skills on how to prevent them from developing diabetes down the line. There are some exceptions where health coaching may not be appropriate, including, for example, active cancer care, severe mental health issues, they're under a psychiatrist or they're under end-of-life care, dementia patients, and generally just patients who are unable to communicate or engage with the service. So a big part of the service is they set themselves goals to achieve, and we work weekly to try and achieve those goals. So if they're unable to make those goals, it would be inappropriate, really. Following a referral, the health and wellbeing coach will then pre-screen the patient from EMIS and then contact the patient to book them into an appointment. How are outcomes monitored? So I use various measurements, quantitative and qualitative. So the quantitative ways are using the PAM score, which is a patient activation measure. High levels of activation are usually linked to an improved health outcomes and reduces costs to the NHS. So patients are more engaged and more take more control of their health, and they see that they need to exercise more to reduce their weight, which would then in turn lower their chance of diabetes and so on. They take that into their own hands rather than constantly contacting GPs or other services looking for a quick fix. That's usually unachievable. The end of treatment review at the end of patient sessions can document any change in measurable outcomes such as weight, the HbA1c level, their blood pressure, lung function, the minutes in exercise, and so on. Due to the service being run virtually, I'm currently using PAM scores. I use the PHQ-9, which is depression score, and the GAD-7, which is the anxiety score. I used weight for some patients who want to lose weight as their target, exercise levels, so how much they do per week, dietary changes, and self-reported changes and feedback is very helpful from patients, from their stories and their feedback. So a lot of the work isn't actually quantitatively measurable. So it's just how a patient feels. So that the patient, after 6 weeks, feels confident she can take control of her weight or take control of how much exercise she does, or she's made lots of dietary changes. It's not necessarily, you know, numbers and figures. It's more that she's confident and she can go forward with that, which is much more powerful and is a long-term sustainable solution. How do GPs know who to refer to which service? So the new roles and the new services that we have are quite confusing. I found them quite confusing to distinguish between, but I've kind of broke it down a little bit. So health and wellbeing coaches are for people at risk of developing long-term condition, such as being overweight, pre-diabetic, diabetic, and so on, but also patients who have one or more long-term condition and are struggling or stuck in some way and unable to make progress. So really struggling to manage with their long-term condition. So I have someone with MS, like I mentioned before, or patients who have COPD or arthritis, lots of long-term conditions that they're stuck living with and are kind of progressively getting worse. They just need support with how to manage and improve their condition. Social prescribing link workers connect people to services other than clinical services which can help them in their lives. So they obviously look at lots of various different areas that Anna and Raquel mentioned. And care coordinators generally help people to plan their care, especially those with more complex care needs with several different professionals involved. So the health and wellbeing service is designed to take pressure off the GP practices by reducing patient visits that are avoidable. It ultimately equips patients to self-manage conditions and any issues they face effectively and independently. So basically it equips them to feel empowered that they can manage their problems that may arise, to manage their weight, their blood pressure, their diabetes risk, and so on. That's it. So yeah, my name is Jamie. I'm, again, like Anna mentioned before, I'm more than happy for any coaches who are new and kind of overwhelmed or want any help or info, just contact me. Just contact Erin. Thank you.
Thank you, Jamie. Our last speaker today, we're going to hear from Gabriel, who's a care coordinator.
Hi guys. Hi, sorry. So I hope everyone can see the screen now. So my name's Gabriel. I'm the care coordinator for South Havering PCN. I've been in my role for coming up to 3 months now. So as everyone's probably aware, it is a very, very new role that's been introduced within the PCN teams. And in the time period that I've actually come into the role, I've been doing a sort of a mixed role, helping out with the vaccination center, as well as developing the care coordinator role and getting to know the other services that are within the PCN. So I'm going to just go through, because obviously being the last speaker, most of the things within personalized care already been covered very well by the previous speakers. So I'm going to go through quickly an introduction to care coordinators as I see it since being in the role for the last 3 months. And then I'll speak a little bit about my own experience and what I've dealt with. So just to begin with, as an introduction to care coordinators, right? So essentially what we're here to do is to support those with personalized care, to build their support plans, review patients' needs and provide them with access to services and support, refer them among social prescribing link workers, health and wellbeing coaches, and other healthcare professionals where appropriate. That is basically like just a small overview that probably is taken from NHSC, but in the role, I found that it's quite a big role, because currently no one has a defined understanding of what the role is. Although it suggests all of these things, I think in the current stage of the care coordinator role, I've come across so many different things that, from a social prescribing point of view, from a PCN point of view, and from a health and wellbeing coach point of view, what the expectations of a care coordinator has to do. Some of it was mentioned earlier today. So when the social prescribers, they were saying that, you know, as doers of the role, you know, they're going to signpost, but someone actually has to do the doing, which they would be doing for other services within the community that they may find. But within a PCN itself, if you find that a patient does need some help to coordinate their care, I do see that as a care coordinator's role. So that is something that you would refer to a care coordinator amongst social prescribers and health and wellbeing coaches. So this is just a little diagram just to show, as already mentioned, that personalized care in itself is massive, and it's not just down to, as Anna was saying, you know, genetics or medicine. There's other things to it, and we do speak to our friends or family or whatever, and we do provide personalized care for them, but there are people within the community that do need that. But what I like to see it as is, I go by this little slogan that I've kind of come up along the way, along my development journey, is to help those that find it difficult to understand, manage, or coordinate their own care. So that kind of leaves it quite broad for anyone to approach us, because that's, you know, they could be suffering from a long-term condition. It's not restricted by age. It doesn't have all of these barriers that some of the roles which, you know, the health and wellbeing or the social prescribing link workers, where they have a more defined role, and they could go through things like, you know, COPD or HbA1c, and they're dealing with them, or weight issues, or social prescribers saying, you know, I can signpost to this person, this person, this person. Or they may have a time frame where they say they work with a patient for a 12-week period, and after that they close off the case. But the role of a care coordinator is something that, me personally, I work alongside 8 practices, and everyone who I've picked up is has got access to my, you know, work mobile number, email address. They can contact me directly, and that relationship and rapport that I build with them continues throughout. So it doesn't just, it's not like a caseload I work on and then I take them off my caseload. It continues. They have access to me. I've had people who I've helped within the community, and then they've come back and they said, oh, can you help this person? And sometimes I've had to, you know, say no, because they're not on my patch, you know, but I've had to pass them on to a colleague and so on. So I think we are at this stage where that there is a support system being built, which is sort of like a triangle of help amongst the roles that are being created amongst the PCN for the personalized care. And it's about making the community aware that these roles exist, and what they're there to do, because at the moment, they're not aware. They may be more aware of social prescribers and health and wellbeing, but care coordinators is quite new. So that's the kind of viewpoint where I'm approaching the role from. And I feel that being on all the webinars and all the training that I've been taking part in, that's the understanding I've come to see. At the moment, how we're approaching referrals is that all 3 services get GP referrals, but as mentioned previously, we will refer amongst ourselves as well, depending on which social prescriber or health and wellbeing coach are within the same circle. So we're currently trying to work on a single point of access referral form, so that when at the point of referral, when the GP is actually making the referral, he can kind of see, okay, they might need social prescribing link worker, but at the same time, they may need some care coordination needs. So that will come to both of us, and we can manage the workload between ourselves. But because it's such a new role and it's developing, there's not anything that me and my colleagues have said, no, it's not something the care coordinators are to do. We've kind of taken everything on as we're still developing it, and as the community becomes aware of that we are here and that they can use this service. So that's just a bit of my contact information. But just to go through some of the things that I've been dealing with. So in terms of the referrals, so I think as of now, the social prescribers have been dealing with carers and referring to adult social care and that type of signposting, but that's something that I've picked up in terms of referrals of social prescribers, that side of things, because after their 12 weeks, they couldn't carry on looking at their carers' needs on a personalized level. But because we don't have a end point as to when we would drop the caseload, that if they needed continuous care, that's something that I'd kind of put on and keep up to date with them, because their needs are going to change. They're at that point where their care needs are going to constantly change, and they might need to go back and forth towards a GP. They might need to be put on some NHS continuing care or palliative care, or they're coming to that point. Or they themselves might be a carer. They might be taking care of someone else. And because we're in uncertain times, I've come across some where they themselves now have been to hospital and there's a difficulty there. So looking after them, and some of it might just be as simple as they have certain conditions that they've developed, which makes it hard for them to now manage the person who they're caring for as well as themselves. So you kind of just, directing them in terms of appointments, keeping up to track with multiple appointments. But some are more difficult where they don't understand what's actually going on in the diagnosis, or where in the consultations that they're having with the doctors, and different areas that they're different avenues that the doctor's kind of researching. It could be this, but it could also be this. And because of their age or because of other health issues that they have, they may be struggling with that. So that's kind of, in terms of care coordination, what we've developed at the moment. I know it's very brief, but as it goes on, I do think it will grow more and more. And as the team grows, I guess it will become more defined as to what care coordinators will essentially be doing. And I do have colleagues in other PCNs who have said they're doing completely different things to where I think I've been quite lucky to be able to develop the role and actually work within a care coordination remit. Some people may, at the moment, as the need is like with the vaccination center, they've only been doing that. So I think as more dialogue takes place, it will become more defined and we'll be able to have something more solid. So yeah, if anyone did have any questions, I'm happy to answer it from what I've learned going forward. But that was just my little piece there. Thank you. Thanks, everyone.
Thank you, Gabil. And thank you to everyone who presented today. We do have some time now. If there are any questions, feel free. You can either unmute yourself and ask them, or put in the chat box any questions on any of the topics discussed today.
So am I saying this right? Humera Sohel. So we had a bit of confusion within our PCN with regards to this as well. So I think in terms of my understanding, correct me if I'm wrong, you guys probably have more experience. In my understanding, there's specific criteria for social prescribers to receive a referral. So in terms of like social anxiety, loneliness, they have a set criteria of things that they can, that you can prescribe to them. I mean, obviously, if it overlaps, the way we're set up, the social prescriber then can send an onward referral to a care coordinator and say, I will address X, Y, and Z, but then can you also look at this patient because they have multiple appointments, they're also care of themselves, they're having difficulty to manage, or they've recently, realize that they have dementia or some other sort of health issues that are stopping them from leading, a normal life, that they do need coordination. So that's how I kind of see the split. Don't know if someone else wants to jump on and clarify it from a social prescribing point of view.
Yeah, I think there is a question, bear with me, about from Mohammed about benefits and filling paperwork. This all depends. I mean, each case is unique. So, you know, depending on the case, we might be able to say, depending on the skills, again, the knowledge of that person, you know, if we see that they are pretty clear on what it is they need help with, we will help. If not, we work with other agencies that provide that one-to-one support that will help checking benefits, and in our case is the local Citizen Advice Bureau, which is called a GP outreach service that works directly with us. So yeah, that's definitely helping with benefits and housing. In that sort of area, we do provide help. Yeah.
Thanks, Raquel. Question from a GP point of view, the outcomes are not always conveyed back to the practice. Is there a clear strategy for this that would encourage GPs to refer?
So if that's come back, at the moment, obviously the GPs are stretched as it is with the workload that they have. So the referral forms are coming through, but all the sort of encounters that we have with any patient should be uploaded on EMIS or whichever vision as a point of, you know, whatever encounters that you have or whatever you're doing. That's my personal point of view on it. So if a GP ever wanted to go back and say, I referred this patient, or if a person of admin wanted to go back, they should be able to go on their system, whichever one they're using, and see what's been done with that patient post referral. And the email addresses are always there, so they can always get in contact personally and say, you know, can I have a response about this patient? And I think they can get it that way as well. Mm-hmm. And just while I was answering that one, there's one about secondary care. At the moment, I don't think the services do receive referrals, if I'm right, from secondary care. It's a primary care referral system. But obviously, if it came through secondary care onto a GP and the GP felt that they needed it, then it would end up with us. But direct referrals from a secondary care point of view, I don't think exists at the moment.
Can I just add to that? Some practices, not so much in our area, but some hospitals do have a social prescribing service in-house. So in that sense, yes, as I said earlier, anyone and everyone eventually and ultimately can refer on in terms of other services. So including acute settings and other services, so it could be the voluntary and statutory services as well. So I hope that answers that one.
I think it's a follow-up to an earlier question. Are different forms needed for social prescribing, care coordination, health and wellbeing coaching?
I think Gabriel has been pointing at that fact earlier on, isn't it? Where you said we're trying to work into, as new teams develop, we will probably need just one-stop shop, you know, that you can say, okay, we got this team and I'm just going to send it. And then we can talk between each other. I can talk to Gabriel and say, oh, I think this is more for you than for me. That's the beauty of it, and having these new additional roles into the teams. But there was another question again about, you know, how do we feedback? All these additional roles are per contract, need access to GP systems. So our input is on GP systems. If for whatever reason the PCN has decided to do otherwise and use other systems like another platform, there are many platforms that other services are using normally in the voluntary sector, okay? But if we have been hired at the PCN level in primary care networks, everybody should have, of these roles, should have access to GP systems, so they can check on what is the progress.
Mm-hmm.
And just to add to that, with a single point, I do believe that even though there's, you know, these three roles were present here, there's more roles coming on. And we all kind of, when we do get a patient referral, do speak to the patient and gather an understanding for ourselves of what we can do for that patient. So just to reduce the amount of workload that a GP has to do, A simple referral form is sufficient with obviously the main purpose of the referral, but we do have our own criteria of what we take away from the patient and what we help them with. So it may just be the GP says needs care coordination help, but that doesn't have a lot of information. But then we have our initial phone conversation with the patient and understand their separate needs and what the doctor said if he didn't have time to put everything down. So having one point of access and then, you know, taking that workload off the GP is the reason why these teams are being created as well within the PCN.
I think that's all the questions that we got. So if that's all the questions from everyone, just one last thing from me is that we have identified previously there is capacity to run another similar session to this for PCNs. So perhaps it'll be a bit more interactive and case-based. So just really helpful if everyone, I'm just going to launch a poll, if everyone could just answer whether that's something you'd be interested in attending in the future.
Sorry, how do we vote on the poll? Hosts don't get to.
Oh. Okay, thank you everyone. Most people have voted. That's really helpful. That's everything from me. So unless anyone else has anything to add or there are any other questions, then I think we can finish up there just a little bit early, but that's all from me. Thank you everyone for coming.
All right, thank you.
Thank you.
Thank you for having us. Thank you guys. Nice seeing you all. Bye.
Bye. Bye.
Bye.
Thank you. Bye.
Bye.